Start of the proceedings in this session. So we have secondary glaucomas, and I'd like to thank Dr. Manoj for giving me this opportunity. So I'll be dealing with the anterior pull mechanism in secondary glaucomas. So this consists of a number of varying disorders which have actually nothing much in common. Good morning, madam. Apart from the fact that there are membranes that form between the cornea and the iris at the anterior chamber. So we'll first deal with uveitic anterior synechiae, and we know that uveitis, there are numerous mechanisms that can cause glaucoma, but we are interested in the peripheral anterior synechiae because that's where the anterior pull mechanism comes. And why does this develop? It occurs because of breakdown in the blood aqueous barrier, which causes inflammatory mediators, fibrin and other mediators to accumulate in the iris, which causes swelling and stickiness of the iris. And when that happens, the iris tends to stick to whatever is close to it, most commonly the anterior lens capsule, but also in the peripheral cornea. So this mostly occurs in the inferior angles because the mediators gravitate inferiorly and the aqueous is most plasmoid at that point. This can also cause secondary vascularization. Now, regarding treatment of uveitis with glaucoma, one important thing to note is that you have to treat the uveitis depending on its merit. So, don't scrimp on steroids thinking that that might increase the intraocular pressure and worsen the glaucoma. So, you have to manage glaucoma separately, give full treatment for the uveitis. Of course, you can use immunosuppressants or modulators if necessary. Aqueous suppressants are the mainstay of treatment, and other medicines like prostaglandins and pilocarpine are best avoided unless you are dealing with burnt out uveitis and you are dealing only with the sequelae. Surgical approach in an active uveitis is rarely needed because the IOP production itself becomes low, and the IOP is usually low in cases of uveitic glaucoma. So, uveitic conditions. So, this is a video of a gonio done in a patient who has recovered from uveitis. The inferior angles, you can see it's all cluttered with pigments and clumps, and fortunately the PAS has not developed, but you can see how bad the angle becomes following a case of uveitis. Coming to the next important group of problems in this anterior pull mechanism is neovascular membranes. Now, the most important thing is it has to be recognized early, because it's usually a secondary problem, retinal disease or vascular insufficiency that causes new vessels to form. And patients sometimes present like a case of acute anterior chamber, acute primary angle closure glaucoma. So they have steamy corneas, sudden loss of vision, raised IOP, vomiting, eye ache, headache. So always differentiate the primary angle closure disease from neovascular membranes. And this you could ask for the history, because there may be history of retinal problems earlier, but also the anterior chamber is typically deeper in such a situation, while in we know that acute angle closure glaucoma, the anterior chamber has to be shallow. You can take cues from the other eye also. Initially the angles may be open, which is when you have to catch these patients, because otherwise it becomes a headache for treating the glaucoma part. Because later it closes like a sheet, and even if the vessels regress, you still get glaucoma due to peripheral anterior synechiae. Treatment is for the primary cause. Anti-VEGF injections, they provide a window of opportunity for you to do TRAB, as well as for the retina person to do their laser or whatever they want to do. So anti-VEGF injections are very helpful in this sort of situations. As previously mentioned, the vessels might regress, but the membranes may not, depending, and they may cause permanent angle closure glaucoma. So this is a post-CRVO patient. You can see very fine new vessels here. So these should not be missed. sometimes they go directly to the retina consultant, dilate in a dilated state, and they may miss it. So always be on lookout for new vessels at the iris. This is the gonio picture of the same person. My PG took only 2 gonio pictures. So this is the vessels at the inferior angle in the right eye, and this is post Avastin injection. You can see that the inferior angles have, the vessels have gone, but all the angles have closed. So this is peripheral anterior synechiae formed due to new vessels at the angle. Coming to the next important group of conditions, the iridocorneal endothelial syndromes. Now the named variants are the Chandler syndrome, which is the most common, usually affects the cornea, progressive iris atrophy, and iris nevus syndrome. Usually in middle-aged women, men also might get it, but almost always unilateral. And this is characterized by an epithelium-like membrane that spreads from the cornea around the angle onto the iris. So epithelium-like because they are actually endothelial cells with epithelial characteristics like desmosomes, microtubules and filaments. So they have a property to migrate, which is highly unlike the endothelial cells. And these migrate as a sheet posteriorly from the corneal surface. Now the characteristic appearance is of a hammered silver appearance of the endothelium, and this is very pathognomonic and has to be looked for. So this is a specular microscopy feature. You can see the left eye is normal, typical hexagonal monosheet of endothelial cells, while in the other eye you can see the cells are ill distinct, they have lost their shape, and you can't really count the cells. One of our patients with Chandler syndrome, seen just a photo like this, you can't really make out what problem this is, but the other eye will be normal, and you have to rule out other causes of corneal edema. This iris atrophy, now this is very glaring, like you can't miss this sort of a picture. Also all the problems of iris atrophy are there, correctopia, dyschorhea, melt holes, stretch holes, polychoria, all that. And this is the other eye of this same patient. Now coming to the other variants, sometimes it may be very very subtle, like this patient, the right eye, you can just see a small dyschorhea, small peaking of the pupil inferiorly, and if it is dilated you might even miss that. The other eye is normal, but you have to be careful while examining a cursory examination, and you might miss this, and the patient might come back years later with severe glaucoma. This is a hammered silver appearance, so this is pathognomonic and can be seen on the affected side. Another very subtle case of iris changes. I have explained this before. 2 patients with the similar findings on the endothelium. Now these 2 photos are of the iris nevus syndrome. These are taken from the net. I didn't get a proper one. So the lighter colored areas are the areas which are abnormal. This is a sheet of abnormal endothelial cells that are spreading onto the iris from the corneal endothelium, and the darker areas, the islands, are the normal iris tissue which are getting pinched up from the surface of the iris. So this causes nodules to form, and this is pathognomonic of this sort of condition. It pulls the pupil down, and you can see some ectropion uvea also. Epithelial ingrowths, these are now rather uncommon following proper microsurgical techniques that we have now, but they can occur following trauma, difficult surgeries, and very painful condition, lots of inflammation. Epithelium membrane forms, they grow through the wound, and they give a typical scalloped appearance growing in from the limbus. This is a less common, this from the net, less common cystic type of epithelial ingrowth. These are more localized, and they are probably easier to manage. Now surgical modalities are required for treatment of glaucoma in these conditions, and even surgical modalities might fail because the epithelium keeps on growing over the internal ostium. Coming to anterior segment dysgenesis, these are classified as secondary childhood glaucomas. They are autosomal dominant with high penetrance, but the expressivity is variable. So you might get one generation with severe iris changes, and the next generation may not have any too much of them. typically bilateral because they are genetic. There are numerous conditions involved in this, but we will focus on axon-filled rigor because that's where the peripheral anterior synechiae are most common. So so this is a gonio photo of a few of the iris membranes that are forming onto the Schwalbe's line. Coming to axon-filled rigor syndrome, axon-filled anomaly is an anteriorly displaced thickened Schwalbe's line. Sometimes they even they are displaced into the anterior chamber. They float into the anterior chamber, and there are always adherent iris strands pulling it downwards. Rieger's anomaly is a congenital iris hypoplasia. They may be associated with correctopia and polychoria, and if they are associated with systemic findings, you will get dental or facial bone defects, umbilical hernias, and pituitary involvement. It's a heterogeneous group of mutations, mainly 3 types, and around 50% of such individuals can get glaucoma. There is a monolayer membrane of endothelium-like cells in the angle, and glaucoma usually occurs in adulthood because of incomplete development of the trabecular meshwork. Now, some of the patients may have very severe iris changes, but the glaucoma may not correlate with those changes. Others have very subtle findings, but the glaucoma may be severe. So, again, few patients with prominent Schwalbe's line. Yeah, you need, as in any childhood glaucomas, you need to manage it surgically. So, in conclusion, various conditions having the same features of the angle closing, peripheral anterior synechiae, secondary. The clue lies in the cornea and the iris. So, be careful. I mean, you have to counsel the patient that they may develop glaucoma later on. And in case of NVI, you need to manage it aggressively with your retina consultant. Thank you.
Thank you, Abdullah, sir. Sir, what about this peripheral anterior synechiae? Can you break it with lasers?
Pardon?
Laser gonioscopy,
No,
gonioplasty.
I don't think so. No, I have not tried that. I don't think that's once the membranes are formed, they are rather thick. You will be hitting on the iris and burning the iris rather than doing anything much.
I don't think.
Now with the advent of goniotomy and all, maybe one can try.
Surgical gonioplasty is there, where we put visco and then try to push the iris backwards. But it mechanically opens the angle, but pressure-wise, I don't think there is a big difference.
Because that will incite some amount of inflammation anyway. So that will again go and stick back.
Trabecular resistance still persists even after mechanically opening up the angle.
Yes, damage to the trabeculum also.
Okay. Thank you, sir.
Thank you.
For the next talk, I invite. Okay. Bring your 5th talk. Dr. Priyanka Sham, consultant glaucoma surgeon, on talk on aggressive push to crisis, secondary push mechanism glaucoma.
Good morning, everyone. I am Dr. Priyanka, and I am going to talk on aggressive push angle closure in crisis. So, the angle closure caused by posterior pushing mechanism is mainly caused by the peripheral iris being anteriorly displaced by aqueous, ciliary body, lens, vitreous, or forces posterior to the vitreous. The rich 4-point classification of angle closure is based on the originating pathology at various anatomical levels. First, at the level of iris, may be due to relative pupillary block or iris thickness and architecture. Second, at the level of the ciliary body, can be due to plato iris, configuration, syndrome, and pseudoplato iris. Then iridociliary cysts and sordid lesions of the ciliary body. Third is at the level of the lens, can be due to enlargement or intumescence, dislocation or subluxation of the lens. Posterior to the lens, the factors are malignant glaucoma, choroidal effusion, angle closure after scleral buckling procedures, after panretinal photocoagulation, after retinal vein occlusion, and posterior segment tumors. Now coming to the pathophysiology according to various anatomical levels. First, at the level of cornea, can be due to smaller corneal diameter, smaller radius of anterior and posterior corneal curvature. Coming to the anterior chamber, it can be due to smaller anterior chamber width, area, and volume. Coming to the iris level, can be due to thickness, rigidity, dynamic increase or lesser reduction in iris volume during dilatation. At the level of the lens, it can be due to thicker lens, smaller radius of anterior lens curvature, and more anterior lens position. Then shorter axial length and choroidal expansion are also other factors. Coming to the diagnostic options, the first one is dynamic darkroom indentation gonioscopy, and then followed by imaging of the anterior chamber, which includes UBM and ASOCT. So gonioscopy is performed with a 4-mirror contact gonial lens, and corneal indentation is subsequently performed to distinguish iridocorneal apposition from synechia. Finally, the slit lamp illumination is maximally increased to constrict the pupil. Thus, this technique allows a dynamic study of the peripheral iris in relation to the angle structures while in motion. Then coming to UBM, it utilizes high-frequency ultrasound waves and provides a cross-sectional image of the structures in the angle and the posterior chamber that are not visible by slit lamp biomicroscopy or gonioscopy. Then coming to ASOCT, it utilizes low coherence light waves and provides high-resolution cross-sectional images of the anterior chamber. Since it's a non-contact operation, it is more patient-friendly than UBM. And however, ASOCT cannot image structures posterior to the pigment epithelium of the iris where light transmission is limited. It provides quantitative measurements of the angle, anterior chamber depth, and central corneal thickness. Gonioscopy provides a wide panoramic view extending across the entire quadrant, whereas UBM and ASOCT provides thin cross-sectional images limited to only one meridian at a time, and hence localized pathology can be missed. So currently, imaging is used only as an adjunctive tool for gonioscopy. Now, angle closure originating at the level of ciliary body can be due to plato-iris configuration, that is an iris with a flat central surface and angulated sharp drop-off of the peripheral portion. Plato-iris syndrome develops in eyes with plato-iris configuration despite the presence of a patent laser iridotomy. This is the UBM of a plato-iris syndrome showing normal central anterior chamber depth and iridotrabecular contact caused by anteriorly positioned ciliary body in the presence of a patent PI. Here you can see the first picture shows the indentation gonioscopy in an eye with plato-iris syndrome, creating double hump iris contour. Second picture shows the UBM of the same eye showing appositional closure of the angle, plato-iris configuration, and anteriorly positioned ciliary body. Whereas the third picture shows pressing on the cornea with the ultrasonic probe, resulting in opening of the angle and creating the double hump sign. Plato-iris syndrome can be complete or incomplete depending on the extent of the iris occluding the trabecular measure. If it is complete, it can result in elevated IOP, and it results in an acute attack spontaneously or following pharmacological pupillary dilatation. Whereas in the incomplete form, there won't be any IOP elevation. Now, secondary or the pseudo-plato iris is caused by cyst of the iris or ciliary body. Lens-induced glaucoma can be due to lens subluxation or dislocation, exfoliation syndrome, and in younger patients it can be due to ciliary block, Weil-Marchesani syndrome, and Marfan syndrome. Mature senile or traumatic cataract with intumescent or swollen lens causes acute attack of phacomorphic glaucoma. Idiosyncratic reaction to several medications can also cause lens-induced glaucoma. Gonioscopy showed a volcano appearance of the iris surface draping over the anteriorly displaced lens, which is called as the Fuji sign, and visible ciliary processes can also be seen. UBM revealed a markedly shallow anterior chamber and iris draping over the enlarged lens and angle closure in the presence of a patent PI. Ocular biometry parameters quantify the extent of the lens mass that crowds the anterior chamber angle, and these are lens axial length factor, relative lens position, and the lens vault. Now coming to malignant glaucoma, it is first described by von Greffe, and the other terms are aqueous misdirection, ciliary block glaucoma, and lens block angle closure. Incidence is 0.4 to 6% of case of incisional surgery for PACG, more commonly seen in females. The epidemiology can be seen in both phakic as well as pseudophakic eyes, and it may be seen after various ocular surgical procedures. These are the rare ocular associations of malignant glaucoma. The risk factors are axial hyperopia, chronic angle closure with plato-iris configuration, nanophthalmos, and history of malignant glaucoma in the fellow eye. Coming to the pathophysiology of malignant glaucoma, it is mainly due to the aqueous being misdirected into the vitreous and resulting in an increased posterior segment pressure, which causes anterior movement of the lens iris diaphragm, thereby resulting in a secondary angle closure. So the key features are shallow anterior chamber, both central as well as peripheral. There is no iris bombay, and also patient has high IOP. Normal posterior segment anatomy, and the first symptom may be improvement in near vision, which is secondary to myopic shift. due to the lens iris diaphragm being pushed forwards. The patient also presents with pain and inflammation and corneal edema. The points to notice: if there is no iridotomy or if patency is in doubt, an iridotomy must be created to rule out pupillary block. If there is a patent iridotomy and a high IOP, then UBM should be done to rule out choroidal detachment and suprachoroidal hemorrhage. If filtration surgery is present, a serial test should be performed to exclude a wound leak, particularly if IOP is not significantly elevated. So, investigations: B scan is done to rule out choroidal detachments and suprachoroidal hemorrhages. UBM as well as ASOCT also helps in the diagnosis of malignant glaucoma. Now, angle closure due to choroidal effusion. Idiosyncratic drug reactions can cause bilaterally shallow anterior chamber and angle closure. The mechanism is by uveal effusion with or without ciliary body swelling. These are the drugs which cause bilateral shallow anterior chamber. Now, coming to the systemic inflammatory diseases, it can be due to SLE or VKH. They cause bilateral four-quadrant annular choroidal effusions and angle closure, which are unresponsive to medical therapy and laser iridotomy. Retinal conditions like CRVO, PRP, scleral buckling procedures can disrupt the retinal and choroidal vascular permeability and interfere with the venous drainage of the uveal tract. Thereby, it causes a unilateral shallow anterior chamber, both centrally and peripherally. Gonioscopy can be done to diagnose the condition. Intraocular tumors like malignant glaucoma, retinoblastoma, and metastatic tumors can displace the iris lens diaphragm forward, leading to angle closure, or by direct infiltration into the trabecular mesh of synachial formation, hyphema, and by iridocyclosis. The diagnosis is done by ultrasound imaging, paracentesis, or vitreous tapping for cytological examination. Coming to the treatment part, the goal of treatment is mainly to reduce the IOP, to reopen the anterior chamber angle and prevent recurrent angle closure, and also for controlling residual IOP if irreversible trabecular mesh dysfunction has occurred. So the medical treatment is mainly by aqueous suppressants, miotics. They are useful in angle closure with an element of pupillary block. Prostaglandins are given in patients with angle closure whose angle is still partially open. Coming to the laser treatment, can be iridotomy or iridoplasty. Iridotomy is done if there is a component of relative pupillary block. Iridoplasty is done if there is residual appositional closure in the presence of a patent PI. They are also useful in plato-iris configuration and lens-induced angle closure. Goniosynoculisis. It's a surgical procedure designed to strip the pus from the angle wall and restore the trabecular meshwork function. The synechia are mechanically separated from the trabecular meshwork under direct visualization through a gonial lens. It is highly successful in eyes with recent synechia. Coming to the treatment of lens-induced glaucoma, drug-induced swollen lens usually responds to medical treatment and they spontaneously resolve after cessation of the precipitating medications. Intumescent cataract, subluxation, or dislocation of the lens are usually unresponsive to medical therapy, and laser iridotomy should be performed in all these eyes to eliminate the element of pupillary block. So, removal of intumescent lens is the definitive treatment of phacomorphic glaucoma. Removal of a clear lens is useful in eyes with recurrent attacks or unresponsive to medical and laser treatment. However, synachial closure, if persisting after lens removal, should be removed by goniosynoculisis. Now, malignant glaucoma treatment is mainly by medical treatment first. First, you should start with mydriatic cycloplegics. These are given immediately to tighten the lens zonules and pull the displaced lens posteriorly, and should be continued indefinitely to maintain posterior displacement of the lens iris diaphragm and prevent recurrence. Then, aqueous suppressants and hyperosmotics should be given to shrink the vitreous volume. Steroids should be given to decrease ocular congestion and inflammation. Then if this medical treatment fails, you can go on to laser hyalodectomy. In this Nd:YAG laser, disruption of the anterior vitreous face is done, which allows direct passage of the misdirected aqueous into anterior chamber. In pseudophakic and aphakic eyes, it is performed through the pupil after posterior capsulotomy. However, in phakic eyes, it is done through a peripheral iridectomy between the ciliary body and lens spaces. If successful, there will be immediate deepening of the anterior chamber and a reduction of IOP. Then laser cyclophotocoagulation is done. It is usually done after failure of Nd:YAG laser anterior hyalodotomy. Single session of treatment less than a quadrant is sufficient. Coagulative necrosis and shrinkage of the ciliary body causes posterior rotation of the ciliary process. Surgical treatment is anterior vitrectomy combined with excision of part of the lens or zonules to establish communication between vitreous cavity and anterior chamber. In phakic eyes, lens removal and intraocular lens implantation may be necessary in addition to vitrectomy. Management of the fellow eye is also important because it is at the risk of developing this condition after any incisional surgery. So prophylactic measures can be avoidance of miotics, prolonged use of postoperative cycloplegics, and prevention of postoperative shallow anterior chamber. So this is a patient who came to me with ACIOL without PI and an IOP of 80 millimeters of mercury. Both peripheral and central anterior chamber were shallow. So patient was diagnosed with malignant glaucoma. We did a peripheral YAC PI and an anterior hyalodotomy. Immediate deepening of the AC and the reduction of IOP was noted. And after 5 days, the AC was well formed with IOP of 10 millimeters of mercury. Now coming to angle closure due to ciliary body rotation. Medical treatment with cycloplegic steroids and aquasuppressants can be given. Miotics are contraindicated. Prostaglandins can be used with caution since they can exacerbate UVL effusion. And if unresponsive, laser iridotomy, iridoplasty or drainage of the suprachoroidal fluid and reformation of AC is done. To conclude, different mechanisms of secondary angle closure presents with specific clinical signs, the identification of which allows for directed treatment of the underlying pathophysiology. Success of medical treatment and surgical intervention is a direct reflection of the underlying etiology. Thank you.
Thank you. Thank you, Dr. Priyanka, for the excellent comprehensive coverage of the topic. Any questions from the audience? Or sometimes it is difficult to distinguish between this pupillary block mechanism and push mechanism because both will have shallow chamber. So in push mechanism, you will have a shallow peripheral as well as central chamber, whereas when you have a pupillary block mechanism, you will have a peripheral shallowing and the central chamber is formed. So that is one way of distinguishing. But sometimes it becomes quite confusing, and sometimes we may choose to do a PA even in a push mechanism glaucoma. Something like a sulfur drug reaction is actually not required to do a PA, but I've seen surgeons who are advising for a PA because there may be a mixed mechanism component they're suspecting. Any additional comments, sir?
Yeah, in lens-induced glaucomas, especially phacomorphic and all, it is very likely that there is some amount of pupillary block mechanism also. So we anyway go ahead and do a PI, and many a time we say that the IOP comes down following PI, and it also helps because it increases the anterior chamber depth. So when you're doing surgery, it becomes that much easier because otherwise you may be having a patient on table without an anterior chamber. It will be like kind of totally, the lens will come and touch the cornea. So you may find it very difficult to form the AC even with viscoelastics. So do a PI in case of phacomorphic and lens subluxations. Some amount of anterior chamber will form. It might help you in doing surgery. Yeah.
Any comments? Anything to add? Nothing? Okay. I'll go next.
Yeah, so I'd like to invite Dr. Manoj Prathapan for his talk on secondary pupillary block glaucomas. Dr. Manoj is consultant at Amrita Institute of Medical Sciences.
Good morning, everyone. So I'll be talking on secondary pupillary block glaucomas. It's important to identify this condition. To know about this condition, to identify it so that we can do the appropriate management. So pupillary blocks have a particular way of presentation. They are usually acute presentation. And on examination, you will see a particular configuration of the anterior chamber. You will have a exaggerated mushroom head appearance, where the peripheral anterior chamber is shallow and the central is formed, and you'll have a iris bombay in between. So causes of pupillary block could be lens, IOL, silicon oil, air, vitreous. It could be inflammatory. Let's go through various cases. The first one is a 1 week post past planar vitrectomy with silicone oil in situ for tractional RD. There is past history of IOL surgery, cataract surgery done 3 years back. So the presenting complaint was acute onset of eye pain and decreased vision with visual acuity of CFCF and intraocular pressure of 60. So this is the appearance. You can see the cornea is steamy. It's a pseudophakic eye. You can see that the eye is pseudophakic, but you can see the iris Bombay. So it's quite possible to have a pupillary block even in a pseudophakic eye. So understanding this, that this is possible, and we can treat appropriately. So you can see the oil reflex also. So this is possible in silicone oil filled eyes. So the mechanism I already explained. So how is the management different? So there is a limited role for mannitol because there is no vitreous to dehydrate. So pilocarpine will not work because there is 360 degrees posterior synechias, so it doesn't work. And PA also has to be done in the presence of a mid-dilated pupil and an attack. So you have to choose an area which doesn't have an iris contact. So it is usually in the mid-peripheral iris that we do the laser peripheral iridotomy. So after giving oral and topical aqueous suppressants, without the use of pilocarpine, we can do this procedure. You can see after the PA is done, the eye is much quieter, cornea is cleared. These are two other examples of silicone oil coming into the anterior chamber to cause pupillary block, but both the situations has already been treated. You can see the inferior iridotomy. This is surgical iridotomy done. If there is a risk of silicone oil escaping into the anterior chamber, the VR surgeon can choose to do an inferior surgical iridotomy. So this kind of escape can happen in weak zonules and if there is a PC rent. This another case, 65-year-old gentleman, pseudophakic for 10 years, underwent past planar vitrectomy with silicone oil for RRD with visual acuity of 6/6. Post silicone oil removal with air exchange done 1 week back, now complains of acute onset of pain. So this is an air bubble induced acute angle closure. You can see a large air bubble filling the anterior chamber. The inferior iris is in contact with the cornea. So there is no aqueous in the anterior chamber at all. That is why the cornea is clear. There is no aqueous to hydrate the cornea. So you have air bubble and then the iris. So here the problem is that there is no space to do a laser peripheral iridotomy. Either it is iris or air. So in this situation, what can we do? So again, pilocarpine is counterproductive. You can't use it. PA cannot be done because there is no aqueous in the anterior chamber, and mannitol again will not work. So the management done here was to keep the patient supine and dilate the patient. So as the pupil dilated, the pupillary block was reverted and the AC formed. So it was as simple as that, and the cornea immediately cleared up. This is a patient who was referred to us by the retinal colleagues who was referred from outside for a nucleus drop on the same day. Patient was referred to glaucoma clinic for digitally hard eye. So this patient was not amenable to the positioning, so we took up the patient for removal of the air. So when you remove the air for burping, make sure that the eye is positioned so that the air bubble comes towards the opening. So here already there is a pre-existing side port entry. Use the same side port entry to allow the air to come out, or else you can use a MVR blade or side port blade to let the air out. If it is done in the other side, you can have an iris prolapse. That is why the air has to come towards the opening site. See, as soon as the air has escaped, the patient feels much better, the eye is quiet. This is another patient who presented post small incision cataract surgery with an ACL implantation with sudden onset of pain, referred as an descented IOL. What we see here is not a descended IOL, it is an iris Bombay. Inferior, you can see the iris Bombay. There is no peripheral iridectomy done during surgery. So some areas the iris is pushed backwards, some areas the iris is ballooned. So this flat iris in some areas is because of the stretch offered by the haptics. So that area iris cannot move forward. But the opposite areas you will have iris Bombay. So just have to do a laser PA and immediately everything is settled. The IOL is in position. Two other examples of pupillary block. One is a phacotopic glaucoma where the lens has subluxated into the anterior chamber completely post-trauma. The other one is an aphakic pupillary block. Now it is not very commonly seen. This patient was aphakic for a long period of time, had a fall, and then developed a pupillary block. This is post-treatment. You can see the inferior PA done, and this intact vitreous face, anterior vitreous face blocking the pupil. Next, coming to uveitic pupillary block, you can try this pupillary block is because of either occlusio pupillae or occlusio pupillae. You can have a fibrin membrane covering the pupil or 360 degrees posterior synechase. So in such situations, intense steroids and atropenizing the eye is the treatment. If it's not successful, we can do a PI. We may need to choose to do multiple PIs, and they should be larger than what we normally do because they have a tendency to fibrose. This is a patient who was post TRD surgery with silicone oil. Now present with the pupillary block glaucomas. So here pressures were very high, and rechamber showed this typical pupillary block appearance, iris Bombay. This is a phakic eye. So we went ahead and did the multiple PIs. You can see 2 PIs, and suddenly the chamber is formed, and pressures also started coming down. And 2 weeks later, this again recurred like we expected. The PI fibrosed, and again the pupillary block recurred. So we knew that there is no point in further doing PI, but we did a temporary laser PI, and something has to be done. So the patient was taken for posterior synecholysis. So the way to do it is to make 2 side ports, one to irrigate, another to put your instrument. This is a sacroiliac spatula going in and releasing the adhesions. Now you can see the AC is forming well. And this patient, again, I thought this is done, and the first 2 weeks the patient was doing fine, the IOP was normal, and the chamber was formed. But then again the patient presented with a similar condition. So again this same problem. So things are not yet over. Again there is a recurrence where the iris is that area. Again there is a posterior synechia, and this has recurred. So now what to do next? So we can either choose to do a phaco with a large surgical iridectomy or a phaco trab for now. So why did I present these cases? To highlight the importance of good slit lamp examination for understanding of the mechanism of glaucoma so that appropriate care can be given. Thank you.
Thank you, Manoj, for those wonderful cases. Now, regarding silicone oil in the eye, this kind of angle closure keeps on recurring. Even if you do PI, it again, closes, and again, it's kind of it's most probably due to some amount of inflammation that's happening due to the presence of silicone oil in the posterior segment of the eye. That causes the PI to close off, and again you may have to repeat these.
There is one patient I did the surgical iridectomy with the vitrector, and that patient did well. A large iridectomy was done.
Very large PA. You need a very large PA. Another good thing, if the patient is pseudophakic, you can do a synecholysis with the laser. With the YAG laser, you offset it anteriorly, and you hit close to the iris and the lens contact where the synechia is forming, and you do that, the synechia breaks and it reverts. But again, it will again keep on coming. So you need to keep these patients on low dose steroids for quite some time. Another thing, when you're doing an ACIOL or iris claw lens, always do a PI, because you might feel on table that it is okay, there is no need of a PI. Why? Some amount of hyphema will be there, iritis will be more, already a difficult case, why do a PI? No, you need to do a PI because a pupillary block is going to happen. You have to think that it will happen rather than delay a PI. In the OP, once the patient develops a very high IOP, it may be very difficult to convince the patient to do another procedure. So always do a PI in case of such if you are inserting such lenses. And if you are instilling air into the anterior chamber following surgery for any reason, always make sure you put some mydriatic after the surgery, or even on table you can put some mydriatic before you close the eye. So that will also again prevent this sort of a problem from happening. Any other questions or comments?
Okay, over to the next speaker, Dr. Meenakshidhar, my mentor. I took my baby steps in ophthalmology holding Madam's hand, so I invite Madam for her talk on overview on secondary open angle glaucoma. Thank you.
Thank you, Manoj, and thank you to KSOS for having me here. It's always home for me. Can I have my slides? After these beautiful talks, I will just be giving an overview of secondary open angle glaucomas, and they occur, we need to suspect them. Number two, one no. We need to suspect them, and in any situation that we should not put it down as a primary glaucoma unless we have ruled out a cause of secondary glaucoma, because otherwise your management and your outcome will be affected. There are many reasons, causes for the same, and I'll just be dealing with some of them. Pseudoexfoliation glaucoma is the most common. Here there is a deposition of white dandruff-like material, exfoliative material, within different parts of the anterior segment of the eye. The deposition may also occur in different parts of the body. This deposition occurs in the trabecular meshwork, and it results in aqueous outflow obstruction and raises the IOP. And in this, it should be differentiated from a true exfoliation, where it is actually the anterior capsule which forms the material, and that happens in glass blowers or exposure to heat or by irradiation. The pseudoexfoliative glaucomas we have to remember that they are more severe. They tend to have a worse outcome, and will be seen very often either unilaterally or bilaterally in patients in older individuals. And both the South Indian population as well as the Scandinavian population is more prone to it. And 50% of patients who have pseudoexfoliation end up having a glaucoma. And since it runs a more aggressive clinical course, we should ensure that we have a good control with whether with medical therapy or with surgery. There is defect in the LOX1 gene, and this leads to in non-pigmented ciliary epithelial cells and trabecular endothelial cells. All of these can produce that pseudoexfoliative material, and that can clog the aqueous outflow. Gonioscopy is of course open. And the trabecular meshwork pigmentation in the fellow eye may be the first indicator of pseudoexfoliation. Treatment, as I said, is more aggressive, and cataract surgery, when done, we need to be more careful, because there is a chance of zonular dialysis. There's a chance that it will be a poorly dilating pupil. We may have to need iris hooks. We may have to put a CTR. We have to ensure that we get a good outcome and decrease our the phaco-dynamic the parameters when we are doing such a surgery. Coming to uveitic glaucoma, where a lot has been said, so I'll just say that more often with anterior uveitis, and both apart from the angle closure type which is there, open angle glaucoma can also be there because of the inflammatory material, and we need to treat the inflammation very strongly, and also treat the IOP simultaneously. It may need surgical intervention. Beta blockers and CIAs should be used first, and one should, as one knows, that avoid PG analogues. Coming to pigmentary glaucoma, it happens, a pigmentary dispersion syndrome may be present if it is without any optic neuropathy and visual field changes. And in glaucoma, it happens more in the young and more often in myopes. Patients have more often in males, and these patients have a slightly flatter cornea, and patients may complain of this halos or blurry vision immediately after exercise. There is an autosomal dominant inheritance to it. The deposition of pigment in anterior segment on the endothelium angle may be seen, and it may lead to a slightly larger pupil. So the classical triad that you have is the dense trabecular meshwork homogeneous pigmentation, and this is how we differentiate it from say in other conditions in which there is a blotchy pigmentation. There is a mid-peripheral transillumination defects may be seen, and the pigment deposition on the posterior surface of the lens may also occur, which is called the Shees or the Zenta-Myers line. And we may also see the Sempolices line, the pigment along the Schwalbe's line, and there may be pigment deposit even on the trabecular meshwork. Pigment release from occurs because of the rubbing of the posterior segment of the pigmentary layer of the iris with zonules, and they tend to have a kind of a double hump pattern. And there is a role of laser iridotomy. Some say that it works. I always do it because this would prevent the repeated rubbing between the iris and the zonules. And especially it is important to do it in the younger people. In older people, by then the pigment has already damaged the endothelial trabecular endothelium and may not have that much of an effect. Coming to steroid-induced glaucoma, of course, all of us know that it does occur, but we need to remember it in situations sometimes, and remember to ask a history for it. It occurs within 3 to 6 weeks of starting the steroids, and if after cessation may come back to normal within 2 weeks. And we should ask for a history of POAG in the family, and there may be a history of a similar such episode if the steroids had been taken before. It has been found to be more often in patients who are diabetics and in the when they are exposed to steroids at a younger age. There may be a connective tissue disease as well, and also in high myopia. There's an increased outflow resistance, and it may be both physical and mechanical changes in the microstructure of the trabecular meshwork. There is inhibition of proteases, and trabecular meshwork endothelial phagocytosis occurs in them. Deposition of this substance leads to expression of fibronectin and extracellular matrix in the deposits in the trabecular meshwork, and hence it blocks the aqueous outflow. It occurs more often. The people who are more at risk of having this are patients. The medicines that cause it most is the diafluprednate, and followed by dexamethasone, prednisolone, loteprednolone, and FML. And it depends on the mode of application. Topical, of course, we all are aware of and we remember as ophthalmologists. Periocular steroids, subconjunctival, subtenons, all these injections may cause it. This occurs a few weeks to months after the use of the injection. And in intravitreal, it occurs much quicker, and there is a triamcinolone within 2 to 4 weeks of giving the injection. It can occur, the IOP can rise, and it occurs faster if there is the patient is not an phakic. And we have to ensure that they are not apply if there is a history of dermatological application or with the non-ocular target or systemic use. And it also depends on how often you are using the product, as well as also how long have you used a product. To summarize, all patients receiving topical ocular steroids, periocular and intravitreal steroids need to be monitored for IOP regularly. Chronic ocular steroids should not be administered by non-ophthalmic physicians unless patients are being also followed up by the ophthalmologist. All patients using dermatological steroids on the face should have a periodic IOP, and high-risk patients should be told about this and managed accordingly. Management here is discontinue steroids, of course, and if it does not come down to normal, very often we need to operate these patients. And if there is a depot steroids, remove the steroids. And if there is an intravitreal steroid, you may need to do a vitrectomy. And the rest of the treatment is very similar to POAG, but they are sometimes really recalcitrant. And SLT may be of some use, but generally they either end up being managed medically or surgically. Neovascular glaucoma can occur of the open angle type, and in later it progresses to angle closure. and there are new blood vessels which are forming, which are whether two-thirds of these patients is either with a history of CRVO or with diabetic retinopathy, and they are difficult to treat, and treatment of course includes anti-VEGF and PRP, trabeculectomy, and the glaucoma drainage devices. Glaucoma can also occur, as Manoj had said, along with retinal pathology. So both the open angle as well as the angle closure can occur. This in silicone oil, it occurs because of the emulsification of the silicone oil, which itself can go and clog the emulsified silicone oil can go and clog the trabecular meshwork, and these spikes can be any time after the surgery or even after removal of the silicone oil. And if one does the gonioscopy in most patients who have had a history of silicone oil, even removal after the thing, you may see a few strands of emulsified thing. And so there can be many reasons that has already Manoj has covered it beautifully. I will not go into that. So these patients need to be treated either medically, and if not, we may need to give an AC wash, and we may need to operate them depending on the case. Then of course we know that after following retinal surgery, whether any vitrectomy or a scleral buckling or photocoagulation, there can be, and even after intravitreal injection, there can be a rise of over IOP, and it will with an open angle. Traumatic glaucoma hyphema, we know that you can have a glaucoma after that, and which is of open angle type, and we need to manage it with steroids, anti-glaucomas, and more often the dorzolamide and the brimonidine, and with tabacetylzolamide and mannitol. Angle recession occurs after blunt trauma in a closed globe injury. In 60% of these patients end up having angle recession. They may end up with a glaucoma either few months or even years after having had this trauma, and sometimes patient may not even remember that they had a history of a trauma. So when one does the gonioscopy, one realizes the classical features of the. I'll just take 1 or 2 minutes, and that happens because of the tear between the longitudinal and circular muscles of the ciliary body, and 5 to 20% of these patients end up with angle recession, end up with a glaucoma, and it's difficult to treat, control it both medically and surgically. Lens-induced glaucoma, all of us know, it could be the phacolytic glaucoma. Apart from controlling the IOP, the lens needs to be removed, or it could be a lens particle glaucoma, or it could be a phacoantigenic glaucoma, and which is of the granulomatous type. Glaucomas can be of the open angle type with tumors, and these tumors, we have to remember that when we are managing them, we should only manage them medically and do any surgical intervention only after the remission of the tumor. The tumor is treated completely. And we can also have glaucoma with a lot of infections, and this is generally of the open angle type. In fact, now it's even thought that there could be bacterial infections, viral infections, even all the protozoal infections. There's a very long list. And in all these patients, it's along with inflammation. And we need to treat the primary disease, where the infection, as well as ensure that the IOP is controlled so that we get a good positive outcome. Thank you for patient hearing. And it's a pleasure for me to be here. And I love Kerala. Thank you.
Thank you very much, madam. Just to add to madam's point, it was an excellent talk, ma'am. Sometimes when there's a steroid response, we can actually change from PRED to DEXA, even though DEXA is supposedly more potent because of the preparation. Prednisolone is an acetate formulation which penetrates the eye better, and dexamethasone is a phosphate formulation which doesn't penetrate. So it acts on the surface very well. So changing from PRED to DEXA can sometimes decrease the IOP in steroid response. And usually steroid response happens after 4 weeks. But sometimes in a pre-sensitized eye, you can have steroid response earlier also. Anything else? Okay, we are having a time constraint, so we'll close the...
Yeah, thank you. Thank you to all the speakers. Meenakshi madam, it's a great pleasure to see you here again in Cochin. I would request Dr. Manoj Prathapan to honor his guru on behalf of all of us here and KSOS Drishti.